Hi, Dr. Vikas.
டேய் கேக்குதா கேக்குதா
Vikas,
கேக்குதாடா?
are you there?
ஹலோ
Case of obstructive jaundice. So today we'll be discussing a case of obstructive jaundice, and I think it is a very important exam case, and all of you are expected to be able to present this case very thoroughly. And by and large, obstructive jaundice is just a very mathematical kind of a thing. So if you do a good history and apply common knowledge, you should be able to reach a very good and very logically derived diagnosis. So over to Dr. over to Dr. Vikas.
குட் ஈவினிங் சார். Shall I start, sir?
Yes.
Good evening, everyone. I welcome you all for this evening session on case presentation. A case of obstructive jaundice. Sham.
You can change the slide.
History. My patient, a male, 64 years, resident of Delhi, retired teacher by occupation. Came presented with the chief complaints of generalized body weakness for past 8 months, complaints of pain abdomen for past 4 months, complaints of yellowish discoloration of eyes and urine for past 1 month. History of presenting illness. He was apparently well before 8 months and he developed with the complaints of pain which was dull aching localized to the right upper abdomen for past 8 months. The pain which was gradual in onset and progressive in nature. Postprandially, pain associated with nausea and vomiting, radiating to back occasionally, which was relieved by taking medications. Vomitus, which was associated with the pain, 3 to 5 episodes in the last 1 month, which was non-projectile, non-bilious, 30 to 50 ml in quantity, which contains only the food particles in the last 4 hours. No blood or no mucus in the vomitus. Aggravating factors of food, no significant relation associated with bowel and bladder habits. Jaundice for past 1 month, which was gradual in onset, waxing and waning type, which was progressive in the last 1 week, associated with itching over the abdominal region and flanks. Urine which was high colored, clay colored stools, which was recently in the last 1 week changed to black colored. History of generalized body weakness, history of fullness of the meals associated with nausea and vomiting, history of significant loss of weight, almost 20 kgs in the last 4 months, from 72 kgs to 52 kgs. 28%, he lost 28% of his body weight the last 4 months. History of loss of appetite, history of fever with the chills and rigors, no history of any mass abdomen, no history of altered bowel and bladder habits, no history of breathlessness. Past history, no past surgical history, no known comorbid illness like diabetic, hypertensive, or coronary artery disease, chronic kidney disease. Personal history, he was married, having 1 son and daughter with no significant ailment. Here he was vegetarian, no history of any substance abuse like smoking, alcohol, beaten and chewing. Lack of sleep, his personal habits, lack of sleep, altered sleep pattern was noticed for the last 1 month. Family history, father and mother died.
Can you give us the summary of patient's present history?
Sir, 64-year gentleman presented with the complaints of generalized body weakness with the loss of appetite and significant weight loss, dull aching pain abdomen associated with nausea and vomiting, postprandially radiating to back, intermittent fever with the chills and rigors, which was subsided by medications, waning type of jaundice with itching over abdomen and flanks, associated with the passing high-colored urine, clay-colored stools, mostly suggestive of obstructive pathology with probably malignant etiology.
Now we'll have to look at each one of them. Your patient is 64 years of age.
Yes, sir.
And he started off with weakness and loss of appetite, right?
Yes, sir. Yes, sir.
Then second symptom that supervened was dull aching pain in the abdomen, which was associated with nausea and vomiting, right?
Yes, sir. Yes, sir.
And now for the
Jaundice.
last 2 months or so, patient is having jaundice,
Yes, sir.
right?
Yes,
And
sir.
it is associated with rigors and chills and associated with intermittent fever, rigor and chills, which subsides with medication.
Yes, sir. And vaccine banning type with passing high colored urine and clay colored stools.
So, what do you think this patient's got?
Sir, it's an obstructive pathology. That is some obstruction in the biliary pathway. That
No,
patient is
actually,
having.
this patient starts off with the problem of loss of weight and appetite.
Yes, sir.
Okay,
Yes, sir.
and loses significant weight, and then he has you know uh, first is of course sorry first is loss of weight and appetite, and then there is pain in the right side of the abdomen, and last 2 months he's having a picture of jaundice. So what do you
Yes, sir.
think it could be? What kind of disease process you would consider in this patient?
Sir, the patient having history of significant weight loss and loss of appetite, which tells us about any malignant nature or any chronic disease like TB, any kind of things, and which points towards jaundice. So it's obstructing the biliary path, or it's obstructing.
You
Uh,
see, I think we'll have to look at it very clearly, and we'll have to look at it this way, that your patient started off with, you know, loss of weight and appetite. Okay.
yes, sir. Yes, sir.
And then the second thing that he developed was pain in the right hypochondrium and postprandial discomfort. And
Yes,
last was jaundice. So if a patient has, you know, a disease in the biliary system, then jaundice should not be so late in occurring. There's not that
yes, sir.
patient will have so much weight loss and patient will have dull aching pain. And then after such a long time, its overall history is 8 months. And now for last 2 months only he's having jaundice. So
Yes, sir.
we'll have to consider the possibility of a disease process which started off in some other region and then started involving the biliary tract secondarily. So it's
Yes,
not
sir.
primarily a biliary pathology. It doesn't look like on the history to be primarily a biliary pathology. It looks like it is a some other malignancy or some other disease which has subsequently started affecting the biliary tract.
Yes, sir.
Now you are having a situation where the patient is having features of uh, cholangitis. Now cholangitis is not seen in any significant biliary malignancy. Cholangitis, which is a syndrome of pain, pain, jaundice, and fever, that is seen not in significant malignant condition. That is most common cause. What are the causes of cholangitis? Can you tell us some of the causes of
Sir, common
cholangitis?
causes CBD stones, uh,
Yes.
gallbladder stone, which progressed to CBD, common bile duct.
अरे CBD स्टोन हो गया ना और क्या?
Yes, sir. Yes, sir.
There's only one cause.
CBD stones, sir. In late cases of gallbladder cancer with liver mets.
Why should a patient of gallbladder cancer with liver mets give rise to cholangitis? Cholangitis happens when there is a partial obstruction to the bile duct.
Yes, sir.
Okay, so
Yes,
stone causes partial obstruction, biliary stricture causes partial obstruction, Mirizi syndrome causes partial obstruction, right?
yes,
And when there is some kind of a system wherein or when there is some kind of a biliointestinal communication that has come to form, this could be a cholecysto duodenal fistula or there could be some operative procedure having been done on the biliary tract. So there are so many causes of cholangitis. So in this patient, if you start with the cause of cholangitis, then which cause of cholangitis would fit it?
Ascending cholangitis.
Huh?
Which type of cholangitis now, sir?
No. What could be the cause of cholangitis in this patient? As I said, cholangitis is seen in very few malignant conditions. What are the malignant conditions you can see cholangitis?
Periampullary carcinoma, which includes four cancer like
Periampullary carcinoma is an important entity that you should remember. Periampullary carcinoma has this tendency of growing and then sloughing off, and in the process, obstruction, which was becoming complete, becomes partial, and therefore patient has cholangitis. So therefore, the only one condition which generally is responsible for cholangitis in a malignant situation is periampullary carcinoma. Or I put it like this, that periampullary carcinoma is one diagnosis which is consistent with the possibility of malignancy or malignant obstruction. As far as head of the pancreas is concerned, cholangitis is not there. As far as Klatskin tumor is concerned, cholangitis is not there. As far as malignant obstruction due to lymph nodes are concerned, that is not the case. So all the other malignant conditions which can give rise to obstructive jaundice do not cause cholangitis. So we have, in such a patient, we should first and foremost focus our thoughts on cholangitis. And if patient has lost so much of weight, he started off with discomfort in the right iliac fossa, right hypochondrium, and then progressed on to develop cholangitis. So what kind of malignant process can account for this kind of symptoms?
sir, ampullary carcinoma.
Ampullary carcinoma, but then I've told you that there is so much gap between the symptoms. This first symptom that this patient had was, a weight loss and generalized weakness. Second symptom that he had was this dull pain in the right hypochondrium. Right. Last is
Yes.
obstructive jaundice. So this sequence means that there is something else that may be there. Could it be that we are dealing with a patient of CA gallbladder? CA gallbladder can give rise to, all the symptoms that you are explaining, that you have mentioned, and then subsequently, you know, so if the patient, you can explain weight loss on CA gallbladder, you can explain right hypochondrium discomfort in this patient, and you can also explain that why jaundice occurred last in the sequence. It occurred last because CA gallbladder has to further increase in and further spread and involve the lymph nodes and or involve the junction of the cystic duct with the bile duct, or there are lymph nodes in the porta hepatis which give rise to jaundice. Now, only thing that I can't explain on the basis of this is the presence of cholangitis. Now, there could always be a situation where because the common um, pre-malignant condition or common association, not pre-malignant condition, but the common association that we have between the CA gallbladder and other entities is the presence of stone in the gallbladder. So this patient may have stone in the gallbladder, which and develop CA gallbladder, and then maybe some of the stone may have fallen into the bile duct. So it becomes a dual pathology, which is not right way of approaching a case. You should always try to explain all the signs and symptoms on the basis of one diagnosis. Right.
Sir, it can
Yes,
be
sir.
head of pancreas tumor, sir, and where the obstruction to the ducts are at the later stages.
So head of the pancreas tumor would result in a very different type of pain. At the head of the pancreas, the pain is in the epigastrium, and it has a very significant radiation to the back. And there is very clear symptom wherein the patient always sits in a hunched up position and trying to sort of bend himself so that there is less pressure on the this peripancreatic neural plexuses. So that's this kind of pain that you are trying to telling me is not consistent. And second is that head of the pancreas generally is not associated with the head of the pancreas generally not associated with cholangitis. Okay.
Sir, in
So
this case, further history of a waxing and waning type of jaundice with the black colored thyroid stools, can I rule out primary causes gallbladder cancer? No, sir?
I would like to keep the possibility of a CA gallbladder. And CA gallbladder generally presents with these, very ill-defined symptoms and then progresses onto all of these things. I would also like to consider the possibility of a CA stomach with, vague symptoms of dyspepsia in elderly patients with weight loss. One should always look at the possibility of the CA stomach, right? So CA stomach can spread to the lymph nodes around the bile duct and give rise to jaundice. Or CA stomach can also spread along the periportal lymph nodes and give rise to obstructive jaundice by way of obstruction at the hilum. So these are the things that you should consider while you are analyzing this patient. So the most important thing in this patient that I would like to account for is significant weight loss. Significant weight loss and generalized weakness with features of obstructive jaundice and cholangitis. So these are the four very important points which we should keep in mind, and we'll try to explain each one of them as we go along discussing the examination part. Okay, move on.
General physical examination. Patient is active, alert, conscious, oriented to time, place, and person. Eastern Cooperative Oncology Group performance status score 2. Karnofsky performance status 60. Weight 52 kg. Height 170 centimeter. BMI 18. Pallor present. Icterus present. No cyanosis, no clubbing, no pedal edema, no
How
left.
do you see pallor in a patient of jaundice? If the patient is having jaundice, he's all yellow. And when you look for pallor, pallor also means that you are looking for some kind of a anemia,
Yes,
right?
sir. Yes.
So how do you look for anemia in a patient who's got jaundice?
Normally, lower palpable conjunctiva we see, sir.
Hmm?
Mm.
Yes, anyone?
Sir, it is the palpable conjunctiva we see for pallor, and for icterus, that is the jaundice, we see the bulbar conjunctiva.
So you are right. We have to look at that area where there is a greater concentration of the capillaries and very little elastic tissue. And lower palpebral conjunctiva and tongue are the two places, where there is very little elastic tissue and more, capillary network. So you can make a comment about anemia on the basis of your observation at the level at the appearance of the lower palpebral conjunctiva. As far as jaundice is concerned, that of course is a very significant thing that you can, significant observation you can make on the basis of the color of the sclera, on the basis of the color of the nails, and also on the palmar aspect of the hand. So these are the areas that you should know, and you should be able to explain it to the examiner that pallor is seen on the lower palpebral conjunctiva because that's where there is less this elastic tissue and greater arborization of the capillaries. You got it?
Yes.
Okay. But if you can't make it out, don't be very focused. Okay, I have to mention about anemia. So sometimes you are not able to make it out, then you can say the patient is too much jaundice and I can't make this observation very clearly.
Yes.
Okay.
Yes, sir.
So
No, sir. Yes.
yes.
No cyanosis, no clubbing, no pedal edema, no left supraclavicular lymphadenopathy. Scratch marks was noticed over abdomen and flanks. No signs of liver failure noted. Patient was afebrile. Pulse rate 82 per minute in right arm. Blood pressure 110/70 millimeter of mercury in right arm sitting position. Respiratory rate 16
What
per
are the
minute.
features of liver cell failure or liver failure?
Sir, ascites, spider nevi, mm, like parotid swelling, testicular atrophy, gynecomastia.
Mm-hmm. Anyone
Hep-
else?
yes, a
Huh?
hepatomegaly.
Hepatomegaly. Is a hepatomegaly in cirrhosis the liver shrinks or liver enlarges?
Cirrhosis. Yes, yes, sir. It's not.
So why do you say that?
Yes, sir.
In
Sorry.
liver enlargement is not a sign of liver failure
Yes,
in
sir.
most of the cases.
Yes.
So what else?
Um.
You mentioned spider nevi.
Yes, sir. Yes, sir.
You mentioned palmar erythema. No, you didn't
No, sir. No,
mention
sir. Palmar erythema, tremors,
uh,
sir. Flapping tremors.
flapping tremors. You didn't mention,
Yes,
and
sir.
then you didn't mention.
Encephalopathy.
Huh?
Encephalopathy, ascites,
Yes,
testicular atrophy.
Peter hepaticus and flapping tremors. So
Yes, sir.
all these things have to be clear, and Dupuytren's contracture
Yes, sir.
and caput medusae.
Yes, sir. Cap.
So I mean, caput medusae may or may not be there, but all these things, you have to look for. So in a patient of obstructive jaundice, first and foremost thing is that we have to look for these signs, and that would be one way of sort of ruling out that our patient is not having what's called as hepatocellular jaundice.
Yes.
Right.
Yes.
So we'll have to always look for the signs of liver failure. Okay.
Yes.
And it should be very clear. Somebody mentioned about loss of axillary hair or scanty axillary hair. Yes, that's right. So it's the estrogen excess which is responsible for some of these symptoms like gynecomastia and this testicular atrophy, because estrogen is metabolized in the liver, and when the liver is not functioning well, then these levels can rise and give rise to these symptoms. Okay.
Yes, sir.
Right. So we now know that our patient is not having hepatocellular pattern, but is our patient is having obstructive pattern. And
Yes.
Karnofsky scale is
60, sir.
60. So why do we need to know about the Karnofsky scale?
Whether patient can able to do his normal routine activities or not, sir. Whether he is ambulatory, whether he decide whether even the patient needs any surgical management, it will tell about the morbidity status.
So it is very important for us to know the Karnofsky status of the patient, because you will not like to offer any extensive surgery to the patient who will not be able to tolerate that kind of a surgery. So therefore, it is very important for you to know exactly that when the patient is mostly bedridden, that is a patient who is not a candidate for any extensive surgical work. And if such a patient has to be made fit, then one has to see whether a period of preoperative nutrition in that patient can help the situation. So it's upfront, such a patient will not be taken up for surgery until you can improve him, or you find a cause that yes, here is a patient who's got an extensive disease and his disease is so advanced that he cannot be any improved any further, and therefore you call him inoperable. So low Karnofsky would indicate towards inoperability. That is the point that you should know. Okay.
Yes. Local examination of abdomen, inspection of abdomen,
So in
and
the local examination that the patient is jaundice and the patient is anemic, did you find anything else? Lymph nodes.
Yeah.
Lymph,
Yes, sir. No any lymph nodes was palpable, sir. No any
which lymph nodes are important?
Sir, if we are suspecting any GA malignancy, we will rule out like a Troisius sign like Virchow's node in left supraclavicular region.
So we
And,
have to look for left supraclavicular lymph node or
Yes.
Virchow's lymph node. What is Virchow's lymph node?
Virchow's lymph node is sir, left supraclavicular lymph node, sir. If
Virchow's lymph node is not supraclavicular lymph node. It's a lymph node between the two origins of the sternomastoid.
yes,
Right. So you should be clear about this particular lymph node. There are two origins of sternomastoid, from sternum
sternum and
and
clavicle.
from the clavicle, sternal head and the clavicular head.
Yes.
So if the lymph node, this classical Virchow's lymph node is present in the two heads of the sternomastoid. But this is Virchow's lymph node. But these patients can also have other left supraclavicular lymph node involvement also. Why not right supraclavicular lymph node involvement?
The thoracic duct drainage is left side. The connection is between left internal jugular vein and left subclavian.
So why does Virchow's lymph node become enlarged? The why does lymph flow into the Virchow's lymph node? It is coming from the abdomen, from the chest, and it is going at the junction of the innominate vein with this internal jugular vein. So why it should go to the Virchow's lymph node?
Because of drainage of thoracic duct, sir. Thoracic duct.
No, thoracic duct drains into the junction of the IJV and the innominate vein.
Yes, sir.
So why should it go to the supraclavicular lymph node? Anyone? This is an open question. There is a valve at the level of this junction of the thoracic duct with the veins, which we have mentioned, and there is at that space there is some time there could be deposits of the malignant cells there, and at the same time, the duct coming from the upper arm is also, or the duct coming from the arm is also draining in the same area. Now what happens is at the time of coughing and such activities, when there's a negative intrathoracic pressure, increased intrathoracic pressure, that time, there could be, retrograde spread of these cells which are present on the wall of this thoracic duct and can go retrogradely and involve the supraclavicular lymph node. So the duct of supraclavicular glands are also draining in that particular area, and these deposits which are present on the wall, they can go retrograde when the patient does some coughing and other activities, and therefore at times, you have these lymph nodal involvement. So it's a retrograde involvement, and the culprit is that valve which is present at the junction of the thoracic duct with the junction of the innominate vein and the IJV. And at the time of coughing, there could be a spread of these cells which are present there to the supraclavicular lymph nodes. So that is the route by which this happens.
Yes.
So this is, I think, important for you to remember. And why it is important? Because it is important for one reason. That is that if supraclavicular lymph nodes are involved, this is an inoperable case. Yeah, it is an inoperable case. So once there's supraclavicular lymph nodes involved, it is considered to be a metastatic disease. And therefore, that means that our approach now changes from any kind of curative intent to a palliative intent. Okay?
Yes. Yes.
Chalo, move on. So I think you should now be clear about Virchow's lymph node and its importance and what is the pathogenesis of its involvement.
Yes, sir. Inspection of abdomen and bilateral inguinal scrotal region. Abdomen is flat, free breathing pattern, abdominal thoracic. Umbilicus centered in position and inverted. Scratch marks was noted over the abdomen. No any obvious swelling seen, no fullness seen in the flanks, no scar, no pigmentation, and no dilated veins around umbilicus, no any visible peristalsis pulsations. The external genitalia were normal, no bulging
Visible,
seen in
visible vein, visible veins, visible peristalsis, visible pulsation, right? And visible lump. You
yes,
have
sir.
to always comment about these things. So, you didn't make any comment about the visible veins, or did you make a comment about the visible veins?
We have to comment, sir.
So, if a patient is having, let's say, caput medusae, portal hypertension, right?
Yes, sir.
So, where these veins will be present, and what will be the direction of flow of these veins?
Sir, normally the vein flow will be towards the umbilicus, sir, and
Mhm.
towards the umbilicus normal blood flow is because of collaterals in portal hypertension. Because of the caput medusae, all blood will flow away from the umbilicus, sir. And in SVC, the flow will be towards lower side. In IVC obstruction, the flow will be upwards, sir.
So, what happens in this caput medusae or portal hypertension? The normal flow is exaggerated. The flow is taking place in the same direction as it takes place in the normal individual, but the flow is now more, right? And that
Yes,
increased flow results in the dilatation of the veins, right? So it
yes,
is the flow above the umbilicus is towards the superior vena cava, and below the umbilicus towards the inferior vena cava.
yes,
And these veins are distributed radially along the umbilicus. Okay.
yes.
And what happens in the inferior vena cava obstruction or superior vena cava obstruction?
Um, Sir, in superior vena cava obstruction, the flow will be towards downside, sir. Downwards, flow will be downwards, downward direction. In IVC obstruction, the flow will be in the upward direction, sir.
So I think it is clear that when there is a superior vena cava obstruction, above the umbilicus, the flow is downwards, and below the umbilicus, the flow is also downward. And in inferior vena cava obstruction, it's just the opposite. So
Yes,
that is how you should look at it. And these veins are not present along the umbilicus; they are present in the flanks. When there is these vena cava obstruction, the veins are present in the flanks and not in the umbilical region. But in the case of portal hypertension, the veins are distributed radially along the umbilicus. So I think
yes,
you should have a very clear understanding about the veins and how to look for the flow in the veins and make a very important comment about it.
yes.
Right.
External genitalia were normal, no bulging seen in hernial orifices.
Okay.
Sir, I can't able to move the slide. Sham.
Just try to you press escape in the
Yes, yes. Palpation of abdomen and bilateral inguinal scrotal region. Palpation due 16 to 6 centimeters soft globular swelling was palpable below right costal margin in the right hypochondrium, was extending into the right lumbar region, which was smooth in surface, firm in consistency, mobile horizontally, moving while respiration, tenderness in the epigastric and umbilical region. No rise in temperature, no guarding or any rigidity, no organomegaly. External genitalia and hernial orifices were normal.
So
Percussion of,
what is this swelling that you are feeling?
sir, it is like a gallbladder swelling, which was mucocele, maybe mucocele or something else.
You call it mucocele.
No, sorry, sir.
Let's be very clear about it. What
Yes.
is this? Is it a mucocele? What is
Sir,
mucocele? What is mucocele?
uh, uh, um, sir, because of obstruction, the bile flow will get obstructed in the initially in the
Mucocele is because of an obstruction of the neck of the gallbladder. by any pathology. Mostly it is due to a stone, right?
Okay. Yes.
So do you think that it is a obstruction at the neck of the gallbladder which has resulted in the gallbladder becoming palpable?
No, sir. No, sir.
So what is the cause of this swelling then? What is happening? Why is gallbladder palpable?
Sir, because of biliary obstruction in the biliary pathway, the flow of
So
bile not able to.
whenever there is a obstruction to the infracystic bile duct, whenever there is an obstruction to the infracystic bile duct, there is the gallbladder becomes distended with the bile,
Yes.
and the proximal biliary tree gets dilated. So you have dilated IHBR. All IHBR proximal to the site of obstruction, they dilate, and so also the gallbladder, because gallbladder will not be able to empty itself, and the fluid, this bile juice will continue accumulating in that to the extent that it can accommodate. So it is a distension of the gallbladder by the
Bile.
liver
Bile.
juice or bile, right?
Yes.
So
Yes.
this is what you have to be, don't use the word mucocele of the gallbladder.
Yes.
Mucocele of the gallbladder is because of the obstruction to the neck, whereas distension of the gallbladder uh, in a patient of obstructive jaundice is due to infracystic obstruction to the bile duct, resulting in all upstream biliary system getting dilated or distended with the bile.
Yes.
Okay,
Yes.
so there is important question here. That is, what is Courvoisier's law, and how do we explain this patient how do we explain this patient's presentation with the Courvoisier's law?
Yes. Sir.
What is Courvoisier's law? First and
Sir.
foremost is that you should be clear about what is Courvoisier's law.
Yes, sir. Sir, in case of obstructive jaundice, if the gallbladder is palpable, then it is not because of stone. Because in case of gallbladder stone, because of stone, there will be minor trauma to the gallbladder, and it leads to fibrosis. So the gallbladder won't be in size won't be in enlarged. So
You should not talk which is not required. You should only talk to the extent that is required, right?
yes, yes,
First is, don't exhaust your knowledge on one question. Keep it up. The most important thing that you should know is that in a patient of obstructive jaundice, if gallbladder is palpable or distended, the cause is unlikely to be stone in the bile duct.
yes,
That is all there is to it. So why it is so? Because if the patient has gallbladder stones, the gallbladder stones originate in the gallbladder, and when they are present in the gallbladder, they lead to multiple attacks of cholecystitis, and cholecystitis results in fibrosis of the gallbladder. Therefore, gallbladder loses its capacity to distend, right? So
yes,
even if the pressure is building up because of the CBD stone, still the gallbladder will not be able to distend itself. And another important thing is that CBD obstruction by the stone is never complete. So therefore, the pressure in the proximal biliary tree doesn't rise to that extent. Okay, so
yes,
that's the reason that when we say that now this is a smooth distended gallbladder which is consistent with the with the accumulation of fluid in the gallbladder. Getting my point?
yes,
Now there is another term when there is a mass in the gallbladder, when there is a tumor in the gallbladder, we do not use the word gallbladder is distended. There we use the word gallbladder mass, and gallbladder mass is quite different from distended gallbladder, right? So distended gallbladder is smooth, it has mobility, and it has all the description that you have given, the size, and it is horizontally mobile. So these are the things that you should be talking about in the context of of this Courvoisier's law. Now
Yes.
we have to look at it this way, that if it is not stone in the bile duct, then what it is? So they say that our gallbladder is just distended, the patient is having obstructive jaundice. Okay, so what could be the cause? Stone is not the cause. What could be the cause?
The Mirizi syndrome.
No, why should you talk about Mirizi syndrome?
Um,
You should talk about obstruction below the junction of the cystic duct and common hepatic duct.
yes, yes.
All obstruction, malignant obstruction in that region can give rise to, uh, you know, obstructive jaundice and palpable gallbladder. So
Like
if there is let's say, periampullary carcinoma, head of the pancreas, or if there is a malignant lymph nodes compressing upon the bile duct, all these conditions can give rise to a palpable gallbladder and obstructive jaundice.
yes.
And cholangiocarcinoma for sure. And all these obstructions have to be to the bile duct below the junction or distal to the junction of the cystic duct. Now you remember this thing. This is a very, very important thing. Okay. If
Yes.
there is an obstruction proximal to the junction of the cystic duct, that is to the common hepatic duct, then gallbladder will not distend. If there is an obstruction to the common hepatic duct or obstruction at the hilum, right, at the
Yes.
porta hepatis, if there's an
Yes.
obstruction at that level, the gallbladder will not distend. Gallbladder can only distend if there is an obstruction distal
Lowest.
to the joining of the cystic duct with the common hepatic duct. So this is something that you should be very, very thorough about. So if you know about the Courvoisier's law, and Courvoisier's law, as you first part of this is, we should be discussing Courvoisier's law very thoroughly, because that is a very important method of reaching the diagnosis. So
Yes.
we said that it is not a stone in the bile duct. Now what it is? It could be any obstruction.
Pathology.
It could be any
Infrancistic.
it could be any obstruction below the cystic duct, and we have discussed what all could be.
Yes,
Could
sir.
there be some exceptions to the Courvoisier's law? Now, what is the exception to the Courvoisier's law? Exception means that the cause is a stone and not it causes some kind of a stone disease. So there's an exception to the Courvoisier's law. What we've talked about is, the Courvoisier's law as it is applicable in a normal situation. But are there some exceptions to the Courvoisier's law? Yes,
Yes,
there
sir.
are
Yes.
exceptions to the Courvoisier's law. What are those exceptions to the Courvoisier's law?
Double stone in one in cystic duct and one in CBD, sir.
Yes. So this is double impaction. So if there is a stone in the cystic duct obstructing the neck of the gallbladder, gallbladder will distend. Just like, it will distend when there is an obstruction to the infracystic bile duct. So gallbladder will distend. And there is a stone in the bile duct which is giving rise to obstructive jaundice. Right. So that is one exception. Is there anything else?
Mirizi syndrome is also.
No, Mirizi syndrome, generally gallbladder is not palpable.
Okay.
Anybody else?
There any malignancy in the common hepatic duct, that is the Klatskin tumor or cholangiocarcinoma above the other common hepatic duct.
See, that is in these situations gallbladder is not palpable. No?
Not
Here
palpable.
we are talking about a situation where gallbladder is palpable and causes something like a stone.
Yes, sir.
So in situations where there is an obstruction at the hilum of the gallbladder, the gallbladder is not palpable. Here we are looking at situation where the gallbladder is palpable and patient is having jaundice and the cause may be a stone. And as he has rightly said, double impaction is one. Number two,
Sir, and
ampullary
gallbladder.
stone. Now
Yes,
look at it. Ampullary stone. Now, ampullary stone or a stone can be a stone of pancreatic origin, which is present in the ampulla. If a stone is present in the ampulla, it can cause obstruction to the flow of the bile and therefore can give rise to palpable gallbladder and obstructive jaundice. So it's called ampullary stone. Another one is Asian cholangiohepatitis. Asian cholangiohepatitis or cholangitis. So these are the conditions, in which there is, Asian cholangiohepatitis. The disease is, I think, of liver fluke, which can get calcified and can give rise to obstructive jaundice and palpable gallbladder. So these are three exceptions to the Courvoisier's law. So whenever there is a palpable gallbladder, first is that it is unlikely to be a stone, and it could be very likely to be an obstruction, most likely an obstruction of malignant nature to the infrahepatic bile duct. But at times, like I mentioned, double impaction or an ampullary stone can also give rise to a palpable gallbladder, and the cause here is not malignancy. You got the point?
Yes, sir.
Okay. So I think this is something, if you have understood, if you have understood this sort of interpretation of Courvoisier's law, then I think I would feel that you have done justice to attending this class. Now, next point is that our patient has a palpable gallbladder and has an obstructive jaundice. He has lost a lot of weight and he is having features of cholangitis. So in this, would you make any diagnosis now?
Periampullary carcinoma.
That's right. So in this context, only diagnosis that can fit in with this is periampullary carcinoma, because periampullary carcinoma is the only carcinoma, which has this picture of cholangitis and palpable gallbladder and obstructive jaundice. So if your patient has features, somebody is asked, I joined it. Can anyone tell me what sir has? Okay, we'll come back to the questions later on. So are you clear about it?
Yes, sir.
So your patient has obstructive jaundice, he has a palpable gallbladder, and he has a history of cholangitis. Now, in this context, a possible diagnosis, if we have to explain everything by one diagnosis, it is periampullary carcinoma,
Periampullary carcinoma.
right?
Dr.
But
Yes.
Malik,
other things,
sorry, can I intervene?
yes, sir.
Yes, sir.
I would like to say, should we use word periampullary or carcinoma head pancreas here? Why specific periampullary? I'm just because periampullary is not part of head of pancreas actually. Right? What do you
Yes,
think?
sir.
Yeah, Dr. Agarwal, I was thinking that, in the when the patient has history of cholangitis and waxing and waning jaundice with palpable gallbladder, which is consistent with the Courvoisier's dictate, then the possibility of periampullary can be made as a clinical diagnosis.
No, you're all right, but I was reading some Blumgard somewhere it was discussed when previously we were very particular that waxing and waning, some blood or this melena, some growth left off and periampullary specifically. But later on it was said that even pathologists cannot differentiate, so probably better word to use head pancreas. This includes periampullary also. I'm just checking if
Yeah,
this is all right or this we have to be
I
specific
think
periampullary.
you're right in terms of the overall ambit is quite clear that one at times one cannot be very specific about these conditions
That is
and
what
these
I'm saying.
yeah
And
absolutely
another thing in Purvaiser's law, gallbladder can be distended when there is a growth at the neck of the gallbladder involving the cystic duct earlier. So that will also be there. Early jaundice and
yes
gallbladder will be distended. Of
yes
course, there
yeah
will not be
absolutely
waxing and waning of jaundice, but
yes
involving the cystic duct, neck of the gallbladder. So they present little earlier rather than fundus growth, which later on involve the common hepatic or common bile duct. But if it
yeah
is involving the neck of the gallbladder, then gallbladder may be distended.
you're
And gallbladder
absolutely
will not
right.
be like malignant gallbladder. It will be soft and
You're very right that when the disease process occurs in the neck of the gallbladder, then
yes, sir.
patient's picture would be that of having a mucocele and extension of this malignancy towards the junction of the cystic duct with the common hepatic duct would result in obstructive jaundice. So
Yes,
it's
that's
actually, but but only issue here, this is one only, and that is this site is less common than the fundus of the gallbladder. So I think though technically it is
But as
possible.
just to complete the list, actually, I was.
Yes, sir. It does complete the list. So the disease occurs at that area and extends towards the common hepatic duct. Then, of course, the presentation of mucocele due to obstruction at the neck of the gallbladder and obstructive jaundice because of the involvement of the common hepatic duct would be giving the similar picture.
Right.
Thank you, sir, for adding value to this discussion. And yes, Vikas, what is your diagnosis?
One more thing. Sorry for interruption.
No,
The
no.
candidate has said that blood flow is towards umbilicus. Normal is away from umbilicus. आपने correct किया था उसको, but candidate has
Away
spoken.
from umbilicus, yes, I did correct it.
He said it is towards umbilicus.
No,
कहते
no.
ना, I flee
I
away
think
from umbilicus, whether lymphatic or venous.
yes. Bilkul, I think I corrected him there itself.
You're corrected. That's right.
Yeah. So I think thanks for highlighting the same point. And I think it's very good for the candidates who are attending this session that they are having the benefit of two teachers giving the wisdom to them.
Sir, I have one doubt, sir. It says right
Yes,
now you commented on some away from the umbilicus, sir. Which one, sir? Like normally the flow will be towards the umbilicus, sir.
No, normally the flow is
umbilicus.
away from umbilicus. It's always away from umbilicus. In above the umbilicus,
Normally.
it is towards the axilla, and below the umbilicus, it is towards the groin. This gets accentuated when the patient has portal hypertension. Same is for lymphatic also. Yes. And inferior vena cava and superior vena cava obstruction, we explained at that time also that if there's an inferior vena cava obstruction, then the direction of flow will be upwards below the umbilicus and upwards above the umbilicus, and vice versa for the superior vena cava obstruction. Means if you remember in portal hypertension, direction does not change. Vein become prominent, but direction does not change. Absolutely, absolutely. That's what. Yes.
Sir, and in portal vein obstruction, the direction is opposite, sir.
Direction means
the extra
umbilicus will be toward inferior and superior will be superior. So direction does not change in portal hypertension.
Yes, a portal vein thrombosis,
but direction does not. All right.
In portal vein thrombosis, the direction is opposite, sir.
No, there is no opposite direction.
No, direction does not change. What I'm trying to say, vein become prominent around the umbilicus, but direction will not change.
Okay, sir.
Because it is not IVC obstruction. Are you getting anatomically?
Yes,
you
sir,
have.
yes, sir.
I think you need to revise your anatomy, Shyam.
Yes, sir. Sir, in portal hypertension, sir, in opposite in portal venous obstruction, then that's my doubt, sir. Sir, in portal hypertension, as sir told, it is away from the umbilicus. But in portal venous obstruction, that is portal vein thrombosis, isn't it the opposite?
It's the same thing, yeah, same thing. Absolutely. You see, the point here is different. And this, I think, when we come to about portal hypertension, we'll discuss a little more about it. At the moment, you just remember what we have told you. And, most of the time, portal venous obstruction, when there is a block at the portal vein, these veins do not become prominent. Why? Now, this is a question you can search in the book and then come back in the next class. I will tell you why these veins don't become engorged or where the caput medusae generally do not form when the patient has extrahepatic portal vein obstruction. These only happen, when there is a intrahepatic obstruction as a cause of portal hypertension that caput medusae come to form.
Have you understood? That will be better during portal hypertension. You can discuss this more detail.
Yes, but portal hypertension, whenever the cause is intrahepatic, then only caput medusae form. When there's an extrahepatic portal hypertension, these caput medusae generally do not form. And I'll tell you why it is so in next time, or you can ask me when we have next class.
I'll ask one thing from postgraduate who's presenting. Why in carcinoma head pancreas there is a portal hypertension? Yes, are you listening?
Yeah, I think it is an important question.
Yes, any postgraduate?
Any liver met, sir? Liver metastasis?
Liver met, why? Liver met does not cause portal hypertension, my dear. By the time patient will be bedridden.
Yes, sir.
carcinoma pancreas, why there is portal hypertension?
The superior mesenteric vein.
Sir, it is a hypercoagulable state, sir.
Splenic vein thrombosis, sir.
Yes, splenic vein thrombosis is the answer.
Splenic vein thrombosis is the right
Thrombosis.
answer.
That's right. That's right.
Yes.
Good.
So I think we have discussed this case clinically now. And now briefly, let's see, what is your diagnosis now? Final?
Sir, my final diagnosis, ampullary carcinoma, periampullary, like ampullary carcinoma, cholangiocarcinoma, carcinoma head of the pancreas, duodenal adenocarcinoma, which was the 4 types of periampullary carcinoma of pancreas.
So I think simply we cannot, on the basis of our clinical examination, we cannot pinpoint, as Dr. Agarwal was very rightly, mentioning in his part of speech, that it is very difficult, to differentiate between all of these three. So it's just simply using the word that head of the pancreas or periampullary would be the 2 important conditions that we would like to consider. Okay.
Right.
Now tell me, how will you confirm your diagnosis? My question is, how will you confirm your diagnosis?
Sir, like in my case, there is waxing and waning type of jaundice is there,
No,
which was...
listen, my question is, how will you confirm your diagnosis?
So by doing further investigations.
Which investigation will confirm your diagnosis?
Sir, first I will go with the normal routine investigations like
Routine
CBD,
investigations do not confirm the diagnosis.
Yes, sir. Dual phase CT, sir. Like ultrasound followed by dual phase CT scan, sir.
Dual phase CT scan will confirm your diagnosis?
And in the sir, and endoscopy also, sir. Endoscopy, upper G endoscopy. If I can able to see some mass, I will can take a biopsy.
How will you confirm your diagnosis? If I ask you, you have to confirm. If I have to ask you, or I'm asking you now, how will you confirm your diagnosis? Can you give me one single answer?
Sir, by doing further investigations.
Which investigation?
Dual phase CT, sir.
But that will only give us an image.
Yes, sir.
An image, of course, can be very useful. And I think image can be very characteristic. It can be quite diagnostic also. But it is not confirming the diagnosis. If I have asked you a simple question, how will you confirm your diagnosis?
The endoscopy with the biopsy, sir.
So if you do an endoscopic ultrasound, it will give you a picture. Where is the lesion? What type of a lesion it is? And you can also simultaneously do a final aspiration cytology and confirm your diagnosis. Or if the lesion is visible, you can always take a biopsy from there, right?
Yes.
Whether this is the first step or not is debatable. That I'm not saying that this is the first thing that you will do. What I have asked you a question was, how will you confirm the diagnosis? So if the question is asked like this, the question confirm means that you have to have a histology. And that means that how do you do the histology of a lesion like this? Either by way of ERCP or by way of endoscopic ultrasound, or by way of, if it's a head of the pancreas lesion, you can do a CT scan and do a final aspiration cytology. But that may not be part of the overall workup of each and every patient. What question here I asked you was, how will you confirm your diagnosis? And confirm of the diagnosis always means that you have something like finality about that diagnosis. And that means that you have to have a histological part. Okay.
Yes.
So now in this patient, what will be your first investigation moving towards establishing diagnosis? Forget about, lab investigation and things like that.
Yes, sir. Sir, dual phase CT, sir.
No, first investigation in a patient of obstructive jaundice should always be ultrasound abdomen.
Yes.
So first investigation in a patient of obstructive jaundice should always be even obstructive or even non-obstructive for that matter, should always be an ultrasound. What all you can find out on the basis of ultrasound?
So lymph nodes. Lymph nodes.
Yeah. First, move in a systematic manner.
Yes.
What all you can find out, what all you can infer, what were the various things that you can find out on ultrasound?
Sir, in ultrasound, we can see the gallbladder, yeah, distended gallbladder and
Distended gallbladder.
CBD
Yes.
diameter.
Huh?
CBD common bile duct diameter. Say if obstruction is there, we have idea about the common bile duct diameter and if ascites is present or not.
Mm-hmm.
And yeah, and to rule out any kidney mass, any pancreas, like other organs.
This is not on. This is not on. So first and foremost, you can see whether there is intrahepatic biliary radical dilatation or not.
Yes.
If there is IHBR dilatation, we are dealing with a patient of obstructive jaundice. First and foremost. Second is what is happening, where is the level of obstruction? Is it at the level of the pancreas? It is at the level of the mid CBD? Is it at the level of the porta hepatis? So you can have some information coming to you from ultrasound about the level of obstruction. What is happening to the gallbladder? You can know whether the gallbladder is distended or it is not distended, right? Next, you can see whether their liver mets are present or not. Though surface mets may not be picked up by ultrasound, but if there are, larger metastatic disease, that can be very nicely picked up by the ultrasound. So you have to make you have to make an attempt to know what is the status of the liver on ultrasound. Then any lymph nodes, peripancreatic lymph nodes, periportal lymph nodes, and celiac lymph nodes can be picked up by the ultrasound. Ascites can be picked up by ultrasound, right? Pelvic deposits can be picked up by ultrasound. And what more? Krukenberg's tumor can also be picked up by ultrasound. So much information you can have from ultrasound. And this is something which is, I think, sets the stage for what should be done next. So ultrasound sets the stage for establishing whether you are having a patient of obstructive jaundice or it is not an obstructive jaundice. In obstructive jaundice, all intrahepatic biliary radicals will be dilated. There will be very few occasions when the patient has obstructive jaundice, when the patient has extrahepatic obstructive jaundice and the biliary dilatation has not taken place. This could be only in the very early phase. Otherwise, biliary radicals are always dilated. So you know whether you are dealing with obstructive jaundice or whether you are dealing with non-obstructive jaundice or other causes of jaundice. Now, what will be the situation in intrahepatic cholestasis? How does the biliary channel look like in intrahepatic cholestasis?
Intrahepatic cholestasis, sir, sorry, sir, I didn't get. Like
how do the biliary radicals look like in case of
dilated, sir, dilated intrahepatic biliary radicals?
No, my question is intrahepatic cholestasis. What happens to the biliary radicals in intrahepatic cholestasis?
Sir, there will be sclerosis will be there because of cholangitis.
So I have always found the students are always very confused. They think that intrahepatic cholestasis means that they should be dilated. No, intrahepatic cholestasis, the biliary channels are not dilated.
Yes, sir, because
There
of
could be
cholangitis.
other evidence of hepatocellular involvement, but biliary radicals are not dilated. Biliary radicals are only dilated if there is an obstruction to the extrahepatic biliary tree starting from the papilla right up to the porta hepatis. Okay, so if the biliary radicals are not dilated, making the diagnosis of obstructive jaundice can be a question mark.
Yes.
Getting my point?
Yes, sir.
So when would you say that, okay, on ultrasound, I have investigated this patient and I think we should not investigate him any further?
Ascites and liver.
So if you find that the patient has ascites, or if you find that patient has metastasis, if we find that patient has deposits in the pelvis, okay, or we find that patient has mets in the liver. No, these are the situations where we know that patient has an advanced disease. So what will you do in these patients?
Sir, in advanced cases, we will go for palliative care, sir.
So whenever we are doing a palliative care, first thing is that we have to establish the diagnosis, right?
Yes, sir.
So we have to either by way of any modality which is available, try and have a histological diagnosis. And that is important for one reason. If we are giving chemo or radiation, nobody will give chemotherapy or radiation even for palliation without having a histological positive diagnosis. Okay. But as far as, advanced disease is concerned, if we know that we are dealing with an advanced disease, we can and if we are not planning to give any kind of chemo or radiation, we can stop that further investigation and take the patient to the what is called as palliative route. And what is palliation?
Bypass. We are not treating the cause, we are supporting the patient with the treatment.
Palliation is offer symptoms to improve the patient's quality of life.
Yes.
Right? If my patient is having jaundice, but he's not having any significant itching, if my patient is not having any cholangitis, and he's just becoming more and more progressively jaundiced, I don't have to do anything. But if my patient is developing significant itching, which is making his quality of life very poor, or if my patient is having very severe cholangitis, which is, creating havoc with his life, that's the time I have to do palliation. So remember, palliation is done for symptoms. If patient doesn't have any symptoms which is robbing him of the quality of life, you don't have to do anything for him. It's only when the patient has symptoms, and we are talking of those patients who have got an advanced metastatic inoperable disease where radiation and chemotherapy have been ruled out in one way for one reason or the other. So these are the patients, you will only do something if they are symptomatic. You will not do anything, just because the patient is jaundiced, you will start putting in a stent. You start doing something for these patients. You start doing some intervention for these patients only when they are symptomatic. If they are not symptomatic, you just have to just look after their other aspect, make their quality of life as good as you can. Right?
Yes.
So that's how, you look at palliation. As far as radiation and chemotherapy for these tumors are concerned, I think they have not shown to be a great promise in the palliative setting. They do not cause much reduction in the size of the tumor, and thereby also do not cause any significant improvement in the quality of life. So I think, barring very rare situation, these radiation and chemotherapy are not used in the context of palliation in these patients. Okay, so that's how, we have discussed one aspect of obstructive jaundice. Maybe next time we can discuss the treatment of obstructive jaundice when we get a patient who is operable and his disease is resectable. So we can look at, a patient of carcinoma head of the pancreas, who has got a good performance status, right? And the disease is resectable. Now, remember these two words, operable and resectable. So when the patient is in good performance status and there are no preoperative information, or there are no preoperative no preoperative information is available about the, let's put it in a little different context. Because,
Yes, sir.
Are you sleeping?
No, sir, no, sir.
Okay, so what I was trying to tell you was that, when do we say patient is inoperable? We say patient is inoperable if the Kornofsky status is very poor, or we have clinical features wherein patient has features of advanced disease like in the neck or ascites or mets in the pelvis, right? So when this, these features of advanced disease are available on either our clinical examination or on our radiological investigation, then we consider these patients are inoperable. The other thing is unresectable. When do we say unresectable? When the disease cannot be resected with an R0 intent. When we cannot remove the disease completely, and that means that the disease has spread beyond the organ of origin and cannot be offered an R0 resection, that will be considered as unresectable. So this is the overall context for our next discussion. Whenever we meet next time and we talk about obstructive jaundice, we'll take this discussion forward. Till that time, if you have any question, we can look at that. I think there's so many questions in this. Let me see if I need to answer anyone. Okay. So I think with this, we just conclude this session. Is Dr. P. N. Agarwal still there on the board?
Yes, yes, I'm there very much. Hello?
Yes, sir. Yes, sir.
I'm here.
Sir, in messages, there's one question. Mild ascites, is it acceptable or not?
Why?
Mild ascites, is it acceptable or not in the messages?
Malignant ascites is not acceptable. It is an advanced disease. You can't operate. Obviously, mild ascites, because of hypoproteinemia or something else, we have to find out.
See, sir, that guy, he is asking.
Is definitely out.
Yes, sir.
Ascites.
He is asking mild ascites acceptable for surgery. For that, further we have to investigate. Then we will come to know by doing further investigation.
Malignant ascites, mild or this thing doesn't matter. But I already said that sometimes it is because of nutritional hypoproteinemia or something. Then you correct it and then it is all right.
Sir, he is telling we operated a patient with mild ascites, but malignant cytologies was negative for malignancy, sir. Like that he is telling.
Oh, so that's
but
what,
how that patient suffered from mild ascites for that guy?
Because of hypoproteinemia, nutritional.
Okay, yes, sir.
Hypoproteinemia will cause mild ascites and edema also. So in general physical examination, you also tell about the period edema or something, albumin is low, then that patient is also not very good candidate for surgery. Anastomosis will not be working properly. If albumin is particularly less than 2, all of you know it. I think I need not to go into this.
So again, he is asking, so we should wait till ascites subside for surgery. If the cytology report was negative, whether we can operate or
actually, if albumin is all right, I don't think there is a problem. But the question is, what is mild ascites? Is there any definition definite that I am also saying mild, you are also saying mild, and Dr. Malik is also saying mild? So that all depends actually individual. We have to individualize the patient and see all the other parameters also, then take a decision. I mean, you may be saying mild. So what is mild actually? Very difficult to quantify. Is there any definition? I'm not very sure actually. Dr. Malik, any comment on that?
Sir, Malik sir, his battery is out, sir. So he just wants me to conclude the class, sir.
Okay. So mild ascites, that's what I said. We could aspirate 50 ml during diagnostic lab. That is also a problem. Once you put in a laparoscope, you always find some kind of ascites. If there is no other sort of contraindication for a resection, I think we can go for resection. If there is no other contraindication, mild ascites, some fluid around the pancreas, very difficult to find out that is malignant. You can go for resection. I don't think there is any problem.
Yes, sir.
Okay.
Yes, sir. Thank you so much, sir. Now we'll conclude the session, and the next session will be based on resectable and non-resectable.
Sure.
Thank you so much, sir. Any passing on comments, sir? Can just.
No, perfectly all right, and I think you have presented well. Except that again, confirm that vein flow, and we can discuss the next case when you are presenting this pancreas. We can talk about that actually.
Yes, sir. Yes, sir. Thanks.
This is a common case. Every postgraduate gets it, and these are the questions which are asked in general. I mean,
Yes.
that is what we expect from a postgraduate, and by and large, quite this thing. Only thing a patient is having cholangitis, obviously, will do ERCP and put in a stent.
Yes, sir.
That is goes without saying. Okay, thank
Yes,
you.
Yes, sir.
Good night.
Thank you.
Yes, sir.
Thank you, sir.
Thank you.
We
Thank you.
conclude the session now.